We are live.
Good evening, everyone. Welcome to iFocus Online, Lecture 118 to Glaucoma Session 22. And we welcome Dr. Debasis Chakrabarti, sir. And he'll be speaking on glaucomas associated with intraocular hemorrhage. And I would request Dr. Vanita ma'am to please introduce Debasis, sir.
Thank you very much, Rolika. When Dr. Debasis was asked to send us a few lines introducing himself, just as he is modest, he sent a very modest bio of himself. It gives me great pleasure to introduce him. He is one of our very own now. He is at Center for Sight in Kolkata. He's a senior glaucoma and cataract surgery specialist there. He did his MBBS from Medical College in Kolkata, previously known as Calcutta, and his MS from the MKCG Medical College, Berhampur, Odisha as it's known now. He did his long-term glaucoma fellowship from L.V. Prasad Eye Institute, and I believe he did it just before I joined there as faculty. He was awarded the FACO in glaucoma, FAICO, that is from the fellowship from the All India Institute of, All India Ophthalmic Society. And he also received one in phaco and cataract surgery. So his areas of interest are in glaucoma surgery, primarily in trab, in tube, in phacotrab, as well as in pediatric glaucoma surgery. So with those words, I welcome him to deliver his talk today on glaucomas associated with intraocular hemorrhage. Debasis, all yours.
Thank you, madam, for your kind words. And it is indeed a great honor and privilege for me to present in this glaucoma module of iFocus. Thanks to Dr. Santosh Sonavar and the iFocus team for giving me this opportunity. So I'll directly go to my presentation, which is on the glaucomas associated with intraocular hemorrhage. So the glaucomas associated with intraocular hemorrhage are usually their secondary glaucomas, open angle type, but we'll see there are various types of this glaucomas associated with intraocular hemorrhage, and there is no conflict of interest to declare. And these secondary glaucomas, we know they form an important category of the glaucomas because the regular glaucomas that we see day in and day out are the primary glaucomas, but we must keep our eyes open to pick up the subtle findings that give us a clue regarding the etiology of the secondary glaucomas. And it is very important to pick up the exact etiology so that we can treat the type of glaucoma appropriately. Now, the most common causes of intraocular hemorrhage, as we all know, are trauma and surgery. And whenever there is an intraocular hemorrhage, there is a rise in the intraocular pressure. If it's a small hyphema, small hemorrhage, the IOP is modest. But if it's a large hyphema, the IOP is high. And this occurs because the trabecular meshwork, that is the aqueous outflow channels, they become obstructed by blood in its various forms. So it can either be fresh blood in case of hyphema or the various products of degenerative products of blood following a long-standing hemorrhage, either in the vitreous cavity or in the anterior chamber. So the broad classification of these type of glaucomas are glaucomas associated with hyphema and glaucomas associated with degenerated ocular blood. So by far the most common type of glaucoma associated with hyphema is the glaucoma that is associated with a blunt trauma. But it can also occur following penetrating trauma. However, the incidence of glaucoma is less because the eye is open and the IOP is low, initially at least. It can also occur following surgical trauma. We will see various surgeries can induce secondary glaucomas. And it can occur in rare instances following spontaneous hyphemas in some intraocular tumors, neovascularization, vascular tufts, and if a patient has posterior synecdoche and we dilate really, that can also cause hyphema. Glaucomas can also be associated with degenerated ocular blood, and there are three categories: the ghost cell glaucoma, hemolytic glaucoma, and hemocyderotic glaucoma. Now, as we all know, blunt trauma has myriad manifestations in the eye, from iridodialysis to lens subluxation, to angle recession, to peripheral anterior synecdoche, and of course, hyphema. Now, various studies have shown that the risk of developing glaucoma after blunt trauma is quite high, and it was found to be around 19% in one study. And the risk of glaucoma after penetrating surgery is less, around 3%. Now, whenever there is a blunt trauma, there is a transmission of fluid pressure to all the walls of the eye. Following the laws of physics, fluid is transmitted undiminished to all parts of the globe. And because of the non-compressible nature of the ocular fluids, that is the aqueous humor and the vitreous humor, there are certain zones in the eye which are susceptible to this shear stress, and they can rupture following this blunt trauma. So Campbell described this classically, the 7 rings. These are the sites, these are the concentric rings which can rupture following a blunt trauma. So they start from the iris sphincter, which can cause radial tears. They can cause a damage to the iris base. This can cause iridodialysis. They can damage the anterior ciliary body, where there is a separation between the longitudinal and the circular muscle fibers of the ciliary body, and this can cause angle recession. Angle recession is quite commonly associated with hyphema associated with blunt trauma, and it can also give rise to glaucoma, which can be detected many years later. It can, the blunt trauma can cause a disinsertion of the ciliary body from the scleral spur. That is, it can cause a cyclodialysis cleft. This, however, will cause a low IOP initially. Then it can cause a trabecular meshwork injury. It can cause trabecular meshwork tears. This can also give rise to secondary glaucoma. And then it can damage the zonules. It can cause lens subluxation and dislocation. So these are the 7 rings, concentric rings, that can be damaged following a blunt trauma. Now, what happens to the intraocular pressure following an immediate blunt trauma? The IOP can initially be low, or it can initially be high. Low IOP can happen because of an inflammation and ciliary body shock, because of disruption in the angle structures, because of a retinal tear, and because of an occult rupture. High IOP, on the other hand, can be caused by a trabecular meshwork obstruction by RBCs, inflammatory cells, or debris from uveal effusion with shallow SE, liberation of retinal photoreceptors in the Schwarz-Matsuo syndrome, where the photoreceptors, they come out in the vitreous cavity, and they can subsequently block the trabecular meshwork, angle recession, and hyphema associated. Now, hyphema is defined as blood in the anterior chamber, as we all know, and the most common cause of hyphema is post-traumatic. It's the most common cause of post-traumatic glaucoma. The annual incidence of traumatic hyphema is about 12 per 100,000 population, and hyphema is an important clinical entity because first of all, the patient is in a shock because there is a substantial reduction in vision. There is significant ocular injury that can be associated with hyphema, and particularly in children, if the hyphema is massive and it is not managed appropriately, then it can give rise to amblyopia. Now, what is the source of blood in hyphema? As we have discussed, there is an injury to the 7 rings, and the source of blood in this hyphema is because of the tear in the iris or the ciliary body, which can cause bleeding from the small branches of the major arterial circle. So if you remember, there is a major arterial circle, which is an anastomosis of the blood vessels around the root of the iris. And this is formed by anastomosis of the 2 anterior ciliary arteries, of the 7 anterior ciliary arteries, and the long posterior ciliary arteries. So there are 7 anterior ciliary arteries, 2 for each rectus except the lateral rectus muscle, and this anastomosis at the root of the iris is the major arterial circle, which ruptures because of this blunt trauma and which causes the hyphema. And from these major arterial circle, there are radial blood vessels which come to the pupillary margin, and they form the minor arterial circle. Now, 2 characteristics of this hyphema clots are that they do not show fibroblastic activity or neovascularization, unlike clots in other parts of the body. And histologically, hyphema clots are an aggregate of erythrocytes which are enclosed by a pseudocapsule of fibrin-plated coagulum. Now, what is the pathophysiology of this blunt trauma? So as we have discussed, there is, following a blunt trauma, there is a rise in intraocular pressure, and this pressure is transmitted across all the walls of the globe. And when there is a tear of these blood vessels of the major arterial circle, there is a response when there is an injury, there are 3 things that happen. There is a vasoconstriction, there is platelet aggregation, and there's a fibrin clot. So there's a transient rise in pressure and globe compression by blunt trauma. The lens iris diaphragm mechanically is pushed posteriorly. There is tearing and distortion of the highly vascularized ciliary body and iris. There is bleeding of the ciliary body, is usually self-limiting due to the elevated intraocular pressure, vasospasm, and clot formation. Now, this clot reaches a maximum organization is in 4 to 7 days. This is important because if we do any intervention prior to this, it can cause a rebleed. An uncomplicated hyphema usually clears by the fibrinolytic system in about 1 week. What is a typical patient profile? It's a young patient. It's more common in males because of more outdoor activities. And the usual setting is either the patient was involved in some sports activity, or there is a motor vehicle accident, but it's an airbag injury, or it's a workplace injury, or it's a physical assault. Now, coming to the clinical examination, we should record the vision, we should check the pupils and the RPD. Very important to rule out a globe rupture. Then grading of the hyphema is important. We'll discuss subsequently. The intraocular pressure should be checked. The dilated fundus examination should be done to rule out traumatic retinal tears, dialysis, detachment, and vitreous hemorrhage. And if the media is hazy, we should go for a gentle USGP scan. It's important to defer gonioscopy and to defer scleral indentation in the immediate post-trauma period, because there's a risk that the clot may be dislodged and there is a risk of rebleeding. Now, it's very important to grade the hyphema because it's an objective quantification of the level of hyphema, and various grading systems are available that we will subsequently discuss. But the simplest technique is to measure the height of the hyphema at the slit lamp. So we can use the vertical slit beam and we can measure the height of the hyphema. And this is a very sensitive way to pick up a sudden increase in the height of a layered hyphema, which is indicative of a rebleed. So when we document this height of the hyphema, when we see the patient first, we can detect a rebleed, or else it may go undetected. Now, what is a grading system? The simple grading system is, first of all, there's a grade 0 or the microhyphema, which is rare RBCs visible only in the slit lamp examination, but there's no layering of the cells inferiorly. Grade 1 is when the hyphema is less than 1/3 of the total space. Grade 2 is when it is between 1/3 and half of the total space. Grade 3 when it's greater than half of the total space, but it's not occupying the full space. And grade 4 when it occupies the entire anterior chamber, and is also called an 8-ball or a black ball hyphema. Why it's called the 8-ball? Because it represents or it resembles the number 8 ball that is that's in billiards. So the number 8 ball is a solid black ball, so it's named after that billiard ball. Now, what are the complications of hyphema? The major complications are associated glaucoma, but apart from the glaucoma, there is risk of recurrent hemorrhage and risk of corneal blood staining. And what are the other complications? It can cause peripheral anterior synecdoche, it can cause posterior synecdoche, it can cause cataract, and it can cause angle recession glaucoma. Now, the glaucoma can occur following an immediate injury due to a large hyphema, but it is more common after a recurrent hemorrhage. And the glaucoma is related to the size of the hemorrhage. The greater the size of the blood clot, the greater is the risk of developing glaucoma. There are certain predictive factors as to which patient will develop glaucoma after hyphema, after a blunt trauma. So this is a hyphema, an increased angle pigmentation, a higher baseline IOP, angle recession, lens displacement, and cataract. And the 8-ball hyphema that we have discussed earlier, it carries a worse prognosis related to the associated glaucoma, because it is a very large clot occupying the entire anterior chamber, so which is blocking all the aqueous drainage. And there is also an element of pupillary block when there is an 8-ball hyphema. Now, frequently, this hyphema is associated with an angle recession. So this angle recession may not be apparent initially because the blood and the associated injury can occlude the view of the angle, nor is it prudent to do a gonioscopy in the immediate post-operative period. But we should also always keep it in the back of the mind that any patient who has undergone a blunt trauma can develop glaucoma that can manifest many years after the initial injury. So always suspect angle recession after traumatic hyphema, because it is seen in as high as 60 to 94% of patients. And the gonioscopy should be done at least after a month after the trauma. And what happens in angle recession is that there's a separation between the longitudinal and the circular muscle fibers of the ciliary body. This angle recession as such is not directly responsible for glaucoma, but it is considered to be a visible marker of an invisible degenerative damage to the trabecular meshwork. So there is some damage to the trabecular meshwork following this blunt trauma, and the angle recession that we see on gonioscopy is not directly responsible, but it's indicative that the trabecular meshwork might have undergone serious injury. Not all patients with angle recession develop glaucoma. Only 7 to 9% of patients with angle recession develop glaucoma. And the risk of angle recession is high if the extent of angle recession is more, particularly if it is more than 180 to 270 degrees. And up to 50% will eventually develop glaucoma in the fellow eye also. So this is an important piece of information, that it has been seen in many studies that patients who develop angle recession glaucoma following a blunt injury to one eye will develop glaucoma in the up to 50% of them will develop glaucoma in the fellow eye also. And that is why many authors consider this angle recession to be an initiating event or a precipitating event in people who are susceptible to develop glaucoma. So the trauma is said to incite this event, and these patients were probably destined to develop glaucoma. Now, what is the mechanism of IOP elevation because of hyphema? As we have discussed, the fresh red blood cells can pass through the conventional aqueous outflow system with relative ease. So fresh red blood cells, they are pliable and they can easily clear the openings of the trabecular meshwork. But when there's an overwhelming number of cells, that's because of a significant hyphema, and this is combined with plasma, fibrin, and debris, this can lead to a transient obstruction of the aqueous outflow. And there is a component of pupillary block glaucoma if the clot is very large and it occupies the whole pupillary aperture like an eight-ball hyphema. Now, if we study this topic in textbooks, and I must say it's discussed in great detail in the Schill's textbook of glaucoma, there is the discussion regarding hyphema and sickle cell disease. So sickle cell disease patients, if they develop hyphema, they have a particular propensity of developing glaucoma. There's increased incidence of IOP elevation in association with hyphema. The erythrocytes in sickle cell anemia have an increased tendency to sickle in the aqueous humor. The elongated rigid cells pass more slowly through the trabecular meshwork, leading to IOP elevation, even with smaller amounts of intracameral blood. And even moderately elevated pressure may affect the optic nerve head deleteriously, possibly because of reduced vascular perfusion. So this is a blood vessel, and this is a normal RBC. And as we can see, the normal RBCs are pliable and they can easily meander through the blood vessels. But when there is abnormal hemoglobin in this condition, which is known as sickle cell hemoglobinopathy or sickle cell trait, the shape of the RBCs become abnormal. They take a sickle shape and they become more rigid, and then they cannot easily pass through these blood vessels, and they become they block the outflow channels. And similar things also happen in the trabecular meshwork, whereas following trauma in the normal person, the RBCs can easily go through the openings of the trabecular meshwork. But in case of sickle cell anemia, even a small amount of blood will find it very difficult to pass through the pores of the trabecular meshwork. And in addition, the sickle cell anemia patients have a propensity of developing ischemic episodes in various tissue organs, and the optic nerve is no exception, and there is reduced vascular perfusion. So this makes optic nerve in sickle cell anemia patients very susceptible. And it is said that in healthy children and adolescents, pressures up to 50 millimeter of mercury can be tolerated for 5 days without permanent optic nerve damage. So the optic nerve can tolerate 50 millimeter of pressure for 5 days without permanent optic nerve damage in case of normal persons. But in sickle cell disease, IOP of 24 millimeter mercury for 24 hours can cause permanent optic nerve damage, and this goes by the name of Goldberg. This is called Goldberg's rule. So only an IOP of 24 millimeter of mercury for 1 day can cause permanent optic nerve damage. So we should be very careful in patients who develop hyphema and sickle cell disease. Now, what is the pathology of the sickle cell disease? If you read the medicine textbooks, we can study in more detail. I'll just pass through the main points. So it's a sickle cell disease is a hemoglobinopathy. It causes a form of hemolytic anemia. And this is because there's an abnormal beta globin chain, and the gene for this beta globin chain is in chromosome 11. There's an amino acid substitution at position 6 of the beta globin chain, where glutamic acid is replaced by valine. So what happens is that the hemoglobin has an abnormal structure, and the deoxygenated hemoglobin in sickle cell anemia, it is less soluble than the deoxygenated normal hemoglobin, or the HbA. And this causes increased polymerization and RBC sickling, particularly in times of stress. So there is microvascular trapping, hemophagocytosis, and the lifespan of the sickled RBC is reduced to 17 days, whereas the normal lifespan of our RBC is around 120 days. So in cases of stress, like acidosis and hypoxia, there is HbS polymerization, and the RBC, from its normal biconvex shape, it becomes a sickle cell. It has a sickle shape, and it causes vasoocclusion and secondary vasculopathy, infection, anemia, inflammation, and this manifests in various organs as stroke, infection, pain, leg ulcers, and chronic kidney disease. So the sickle cell disease affects various organ systems of the body. So in the eye, it can cause retinopathy, it can cause retinal infection, and it causes post-hyphema glaucoma. Now, is sickle cell disease common in India? Well, it's very common in the African countries, but it is also quite common in India, particularly in some areas where there is a large number of Adivasi population. So in those populations, the sickle cell anemia is quite common. Okay, so the other thing that can happen with hyphema is recurrent hemorrhage. So this recurrent hemorrhage typically occurs in the first week, that is within 2 to 5 days after the initial injury. So why it happens? It's probably related to the normal lysis and retraction of the clot that initially controlled bleeding. So the bleeding is initially controlled, as we've discussed, by the vasospasm and the platelet and the fibrin aggregate, and it forms a clot. But then there is a subsequent mechanism of this lysis and retraction of the clot. The reported frequency of this recurrent hemorrhage is 4% to 35%. Now, how can we detect there's a recurrent hemorrhage? We have to follow up this patient very closely, and we have to document the size of the hyphema that we've discussed in the first visit. So whenever in the subsequent visit, there's an increase in the size of the hyphema, or when we find a layer of fresh blood is noted over the older clot in the anterior chamber, we can detect that there is a rebleed. The significance of this rebleed is that patients with rebleed have a greater than 50% likelihood of developing glaucoma. Now, what are the risk factors of rebleeding and what are the complications of rebleeding? Patients who have a large size of the initial hyphema, patients who are on aspirin or other non-steroidal anti-inflammatory drugs, patients who have an IOP of more than 22 millimeter mercury at the first exam, patients with sickle cell disease or trait, patients of African American race, patients who are taking antiplatelets or anticoagulants, and patients who have systemic bleeding dyscrasias. So obviously these patients, they have more risk factors of rebleeding, and we should be more cautious. And what happens? What are the complications of rebleeding? So when there is a rebleeding, of course, there's a substantial increase in the size of the hyphema, and this causes a secondary rise in the intraocular pressure. So the intraocular pressure rise is much higher if there's a rebleed compared to the initial hyphema. There is also the risk of corneal blood staining. And if the IOP, if the rebleeding is not detected, if the patient is not followed up adequately, if the IOP is not controlled, then the patient will develop optic atrophy due to glaucoma. And the patient can also develop the peripheral anterior synecdoche, which can give rise to a secondary angle closure glaucoma. So all these are the risks of rebleeding. That is why we should be very cautious to detect and treat a rebleed. Now, what is the risk of vision loss from hyphema? The risk increases with the degree and the duration of the elevated intraocular pressure, and the risk increases with the risk of rebleeding. So one study has shown that the prevalence of glaucoma in hyphemas it's about 13.5% in grade 2 hyphema, 27% in grade 3 hyphema, and more than 50% in case of total hyphema. So very high risk of glaucoma if the patient has a total hyphema or very significant hyphema. And also angle recession is seen in about 60 to 94% of patients with traumatic hyphemas. Corneal blood staining is the other important aspect of blunt trauma associated with hyphema. And the corneal blood staining is more if the hyphema is more and the IOP is high. Why is there corneal blood staining? The hemoglobin is phagocytosed by the keratocytes and it is degraded to hemocydin. And initially the color of the cornea is red because of the breakdown of the hemoglobin. And then the cornea acquires a brownish discoloration due to the accumulation of methemoglobin in the stroma. The clearing of the corneal blood staining begins in the peripheral part and the posterior stroma, and it takes many years, and it may take up to 3 years to clear completely. So this is also another permanent cause of visual loss if the patient has significant hyphema. So that should also be taken into consideration. So what should be the management of hyphema in general and the management of glaucoma associated with hyphema in particular? The conservative management is done with limiting ambulation of this patient, elevation of the head end of the bed so that the blood gravitates and the visual axis is cleared of any blood. You must avoid aspirin and NSAIDs because these patients, many of these patients have significant trauma, and reflexively we can write NSAIDs for this pain. You should avoid aspirin and NSAIDs, and we can prescribe paracetamol instead. The patient should have a protective eye shield because any second injury to the eye can cause a rebleed and significant damage. The patient also are started on cycloplegics because this will dilate the pupil. This will relax the ciliary body, so the patient will have less pain, and there is also it will reduce the risk of developing the posterior synecdoche. Topical steroids are used. Topical steroids can reduce the inflammation, they can reduce the pain, and they can also decrease the fibrin. And there is a doubtful role of systemic steroids. Some authors suggest systemic steroids, others do not. In the textbooks for acceleration of hyphema clearance, intracameral tissue plasminogen activator has also been described. And very important to prevent rebleeding, for these oral fibrinolytics are available like aminocaproic acid, tranexamic acid, and aminomethyl benzoic acid. They are said to stabilize the antechamber blood clots. They can delay the clot retraction and they can reduce rebleeding. But they're contraindicated in patients with disseminated intravascular coagulation, contraindicated in pregnancy, coagulopathies, or patients who have renal disease or hepatic disease. Out of these, tranexamic acid is available quite easily, it's available as tablets and it's available as injections. So this tranexamic acid, it has fewer side effects and it is more potent than the aminocaproic acid. And some studies have also shown that topical tranexamic acid 5%, where this it's mixed with this artificial tears, that can also be tried with good results. And most importantly, we have to control the intraocular pressure. So how to control the intraocular pressure? It is just a standard means of controlling glaucoma. So the most preferred drugs are the aquasuppressants like the topical beta blockers or the alpha-2 adrenergic agonist, that is brimonidine, or carbonic anhydrase inhibitors, or any combination of these topical anti-glaucoma medications. When it is not adequately controlled with topical medications, we can go for the systemic carbonic anhydrase inhibitors, oral glycerine, or intravenous mannitol. PG analogs and pilocarpine are not recommended in this scenario because they can induce inflammation and can cause more damage. Systemic carbonic anhydrase inhibitors are contraindicated in patients with sickle cell hemoglobinopathies. So you should not use acetazolamide in patients who are known to have sickle cell anemia or sickle cell trait. And the topical carbonic anhydrase inhibitors are also not preferred because they can they are contraindicated. The systemic carbonic anhydrase inhibitors, they can induce acidosis and they can promote more sickling. Now, some studies have shown that in patients who have sickle cell anemia, transcorneal oxygen therapy, that is humidified oxygen 1 to 3 liters per minute, they can dramatically reduce the IOP in patients with sickle cell and high fever. Now, what are the indications of surgery when there's a large persistent high fever? Usually more than grade 3 high fever for more than 10 days. Then when there's corneal blood staining, as we have seen that corneal blood staining can cause permanent reduction in vision. And then uncontrolled IOP despite maximum medical therapy. So there are certain guidelines. So these are the usual limits of tolerance of the optic nerve, like a 60 millimeter mercury pressure for more than 2 days, or 50 millimeter mercury pressure for more than 5 days, or 35 millimeter mercury for more than 7 days, or 25 millimeter mercury for more than a day in sickle cell disease. So when we have IOP such high, then we should not wait and we should go for surgery. Now, what is the ideal timing for surgery? The 4th day after injury is said to be the optimum time for removal of the clot, because by that time the clot has properly formed, and even if we remove it, there is a less risk or minimal risk of rebleed. It's important to understand if there's a delay of indicated surgery beyond 1 week, there is a risk of developing permanent optic nerve damage. Now, how to remove this blood clot? So the simple paracentesis can be done. So paracentesis with a 30 gauge 0.5-inch needle attached to a tuberculin syringe. This can provide short-term relief of extreme high IOP spikes, but it's of little use with total high fevers. So it can be done even in the OPD at the slit lamp. You can use a needle, you can put topical paracape, and you can just remove a drop of aqueous to reduce the intraocular pressure. But it is very important to understand that we must avoid massive reduction in intraocular pressure, resulting in hypotony, and possibly a rebleed. So this is not suitable in all situations. Anterior chamber wash is very effective in most cases. So we can use a simple 2-port anterior chamber washout with nasal and temporal clear corneal incisions, just like we do a cortical aspiration in a routine phacoemulsification. So BSS is irrigated through one corneal incision, while the posterior portion of the other incision is depressed to evacuate the blood. So we must keep the bottle height high, because we must not allow the AC to shallow or the IOP to fall down, because there's a risk of rebleed. Now, if an adequate amount of blood is not removed by the IA port, because the port opening may not be adequate to remove an extensive clot, we can use a handheld IA unit, that's a Simcoe cannula that we use in SICS. It may be inserted into one corneal wound for gentle clot removal. But for organized high fever, AC washout using an automated anterior vitrectomy through a limber or clear corneal incision may be required. So it's a very organized clot. We may have to remove this anterior vitrectomy system. And we should remember that this vitrectomy should be on the irrigation cut aspiration mode to avoid traction on the clot and angle structures. So we should avoid traction on the clot and angle structures and minimize the risk of rebleed. Whatever technique we employ, we must remember that a complete extraction is not necessary. Even if you remove a significant amount, the IOP will come down and the rest of the high fever can be tackled in the natural course of the disease. Care should be taken to maintain a formed anterior chamber. If intraoperative rebleeding occurs, tamponade with a viscoelastic such as sodium hyaluronate 1% or air is quite useful. Rarely, diathermy with 23 gauge endodiathermy needle may be needed. And we must remember to close the corneal wounds with 10-0 nylon. This is a simple video. Which shows the technique of this removal of the blood clot. So as we can see, there's a massive blood clot in the anterior chamber. So with a 15-degree sharp blade, paracentesis is met, and the posterior of the septum is gradually come out.
Debasis, sorry to interrupt. Your voice is not audible.
Okay. Is it audible now, madam?
Yeah, better. Thank you.
Right. Okay. So we should adequately irrigate the anterior chamber by ESS, wash the hemolyzed blood. it's very important that we keep the anterior chamber formed, and we can take the help of an AC maintainer if we're not using a simple cannula. And then the clot is gradually aspirated. So you can see with a simple cortex aspirator, the clot is being aspirated and it's gradually being released from the wound. So gentle pressure is being applied to the posterior lip of the sclera, and the clot is being extracted through it. The clot can be broken into small fragments for ease of delivery. And the anterior chamber is formed with an air bubble. And the wound is closed with a N0 nylon suture. Okay, so the removal of the clot by various means is usually adequate to tackle the hyphema, but in rare instances, when the IOP is very high, a trabeculectomy may be needed. So for large hyphemas or clots with profound elevation in intraocular pressure, we can resort to trabeculectomy. And when we do a trabeculectomy, a washout or partial clot removal can be performed through the trabeculectomy site only. The immediate IOP reduction is the goal of the surgery, of course, but in the face of the acute inflammation that we are doing the surgery, there is always a risk of failure of the trabeculectomy. But ultimately, what we need is IOP control in the short term so that we can prevent the optic nerve damage. And we should be careful to secure the scleral flap to avoid early hypotony, and to use releasable sutures or use argon laser suturolysis. The patient should not go into hypotonia for the trabeculectomy. And there is no need for antimetabolites unless the patient has pre-existing severe glaucoma. So this was about the blunt trauma. Now we come to the penetrating injuries and the glaucoma that followed thereafter. So the associated glaucoma following penetrating injury is less because the wound is open and the IOP is usually low. However, if the wound closure is not done appropriately or the inflammation is not tackled appropriately, then many of these cases can develop secondary glaucomas. So we have discussed the glaucomas following the blunt trauma and the penetrating trauma. Now we will coming to the hyphema associated with intraocular surgery. So these can intraoperative, the hyphema can be intraoperative, early postoperative, or late postoperative. So intraoperative bleeding, it can happen in rare instances, like trabeculectomy is one surgery where there is an intraoperative bleeding that can occur. However, it's usually mild. While doing an iridectomy, it can happen. While doing a tube implant, in case of a neovascular glaucoma, this bleeding can happen. And I have personally experienced bleeding while inserting a multi-piece intraocular lens. The haptic can suddenly jut out and it can hit the iris root, and that can cause very severe bleeding. And I have seen one patient was operated elsewhere. He had very significant hyphema and permanent glaucomatous optic nerve damage following this sort of injury. Now, what happens, what we do when something like this happens, a large air bubble or a viscoelastic agent in the anterior chamber for a few minutes, it raises the IOP and it acts as a tamponade and controls the bleeding in most situations. In other instances, we can apply direct gentle pressure with the tip of a sponge or gel foam, or apply epinephrine to the ciliary body for 1 to 2 minutes, and that can cause ciliary body bleeding. And we can, of course, use the weight-filled cautery like we do in a trabeculectomy. While doing the conjunctival dissection, we should cauterize the bleeding areas, particularly the areas of the perforating vessels. So the weight-filled cautery should be used to control the bleeding intraoperatively. Now, early postoperative bleeding can again be a complication of trabeculectomy, tube implant, SICS, or diabetic vitreoretinal surgery. Recently, we saw a patient following a diabetic vitreoretinal surgery. There was vitreous hemorrhage and subsequent a significant hyphema that had to be drained. So it can happen in such situations. But small hyphemas after intraocular surgery, they normally clear rapidly, although the time may be considerably longer in patients who have pre-existing glaucoma. So if it's a glaucoma patient and develops a postoperative hyphema, we should be extra careful. what we should do this, we should limit the activity, and we should advise elevation of the head end, conservative medical management with aqueous suppressants and hyperosmotics. Frequent topical steroids can assist in clearing clearing the fibrin. Intracameral use of tissue plasminogen activator has also been suggested, and surgical intervention can be resorted in very critical cases. Okay, then other thing is the late post-operative hemorrhage. This is quite unusual, but we again have seen some instances. What happens is that there can be disruption of new vessels growing across the inner aspect of a corneoscleral incision. If the patient has undergone an SICS or an ECC, sometimes this happens. There is a proliferation of blood vessels at the inner edge of the incision, and there's some raw area, and that can bleed. And I had also in the recent past seen a patient who had undergone trabeculectomy several years back, 5-6 years back, and the patient had a peculiar complaint of developing sudden blooding of vision in the early morning that cleared subsequently. So this went undetected until one ophthalmologist, while examining the patient, found blood trickling from the 12 o'clock position. So there was a raw area in the trabeculectomy wound, and the patient probably had some faulty sleeping habit, and there was some minor trauma during sleeping due to the age of the pillow or something, and that caused this bleeding in the early morning. So once we detected it, we simply advised the patient to put an eye shield, and the patient actually he did not have any similar episode in since the last 1 year or so. So, and again, argon laser therapy has also been advised. If you can find the vessel gonioscopically, you can hit these vessels. Now, spontaneous hyphemas are very rare, but there are certain instances where they can occur, like intraocular tumors in case of children, like juvenile xanthogranuloma or retinoblastoma. In case of adults, it can happen in malignant melanoma. It can happen in neovascularization conditions like neovascular glaucoma, Fuchs heterochromic cyclitis, or other uveitis. It can occur in vascular tufts of the pupillary margin. This is a unique condition, and it can occur in a patient who has posterior synecdoche. And when we dilate this patient, hyphema can occur. So these vascular tufts of the pupillary margin, these are sometimes seen. These are also called iris microhemangiomas. Slit lamp examination reveals multiple vascular tufts along the pupillary margin. More common in older adults. Probably there's some association with diabetes mellitus and myotonic dystrophy. And spontaneous hyphemas occur in a few of these cases, and laser photocoagulation can be done if they're detected. Now we come to we have detected the glaucomas associated with fresh blood. Now we come to the glaucomas associated with the degenerated ocular blood. So there are three distinct entities: ghost cell glaucoma, hemolytic glaucoma, and hemocyderotic glaucoma. Out of these, ghost cell glaucoma is the more common. Hemolytic and hemocyderotic glaucomas are rare. So I will discuss the ghost cell glaucoma in some detail. So ghost cell glaucoma is basically a secondary open angle glaucoma, which is caused by degenerated red blood cells, which are called the ghost cells, which block the trabecular meshwork. So initially, the cause was not known. It was not known what is exactly causing this glaucoma, but then Campbell and his colleagues finally showed that it is a form of the degenerated derbises which causes this actual glaucoma. And the typical setting is a long-standing vitreous hemorrhage, but it can also occur in a long-standing hyphema. So what basically happens in this condition is that when there is a long-standing vitreous hemorrhage, there's a degeneration of the red blood cells, and these red blood cells, they become the ghost cells, which have less pliability compared to the red blood cells, and then they enter the anterior chamber, and they temporarily block the aqueous outflow. So this is the diagram. There's a vitreous hemorrhage, and in the vitreous cavity, they are converted to ghost cells, and through the hyaloid phase, they enter into the anterior chamber, and these are the ghost cells. This is a typical appearance, and they block the trabecular meshwork. So having entered the vitreous cavity, the fresh erythrocytes are transformed from the typical biconcave pliable nature to tan or khaki color spherical and less pliable structures, which are referred to as ghost cells. And histologically, they have a typical appearance. They have thin walls. They appear hollow, except for clumps of denatured hemoglobin, which are called Haynes bodies, which adhere to the inner surface of the plasma membrane. So if you can see these RBCs in this slide, some of these, they have the hemoglobin aggregation in the adhering to the inner aspect of the cell membrane, but the rest of the cell is empty. So that's why they're called the ghost cells. And these aggregates of hemoglobin are called the Haynes bodies. So these ghost cells, they typically develop within 7 to 10 days of the vitreous hemorrhage, but they may remain in the vitreous cavity for many months until a disruption of the anterior hyaloid allows them to enter the anterior chamber. And the disrupted anterior hyaloid phase can occur from previous surgery, like perspinal vitrectomy or cataract extraction or capsulotomy or trauma, or there can be spontaneous disruption also. The size of these ghost cells is generally 4 to 7 micrometer in size. The size of a typical RBC is about 7.2 micrometer. And unlike fresh red blood cells, these ghost cells do not pass readily through the human trabecular meshwork. And once in the anterior chamber, these abnormal cells accumulate in the trabecular meshwork, where they may cause a temporary, but occasionally there's a marked elevation of IOP. It can even reach up to 50 to 70 millimeter of IOP. What are the common clinical settings? A patient who has undergone vitrectomy for diabetic retinopathy, cataract extraction with vitreous hemorrhage, which can occur pre-op or intra-op or post-op, a patient who has vitreous hemorrhage without surgery, like a patient following trauma, a patient with diabetic retinopathy, or a typical type of snake bite called the protallid snake bite has also been associated with this condition. And recently, intravitreal injections have also been implicated. You see, many of these intravitreal injections are given in patients with proliferative diabetic retinopathy, and they can have vitreous hemorrhage. And when these intravitreal injections are given, they are somehow triggering this transmission of this ghost cells from the vitreous cavity to the anterior chamber. And in these patients following intravitreal injections, this ghost cell glaucoma can occur early. So although studies suggest that the disruption of the anterior hyaloid phase may be a necessary precedent, ghost cell glaucoma probably can occur with an intact hyaloid if a sufficient quantity of vitreous blood is present. So even if the patient has an intact hyaloid phase, if there's a very significant vitreous hemorrhage, this ghost cell glaucoma can occur. So how can we detect this ghost cell glaucoma? So that diagnosis can be easily missed if you don't remember these findings. So the diagnosis is essentially clinical. There's usually a history of a vitreous hemorrhage 1 to 3 months prior to presentation. Typically, they have very high IOP, but the pain is less compared to the level of the intraocular pressure. The patients have blurry vision. They can have headache and brow ache and nausea and vomiting because IOP may at times be very high, but the conjunctiva is usually quiet. The corneal edema can be significant, and the IOP, as we've discussed, can be very high. And a very important feature is that they will have a delayed onset of IOP rise following the triggering event. So the vitreous hemorrhage may have occurred several months earlier, but the patient now presents with this very high IOP. So you should have this diagnosis of ghost cell glaucoma at the back of your mind. So what are the typical findings? There's some typical clinical features, like the slit lamp examination reveals characteristic khaki colored cells in the aqueous or on the corneal endothelium. And if fresh red blood cells are also exist along with this khaki color cells, this causes a typical candy striped appearance. So this is a striking appearance. If you find this appearance, it's a typical finding of a ghost cell glaucoma. This grayish yellow thing is a ghost cell precipitation, and this RBC is a fresh bleeding that has occurred. Now, there is a lack of keratic precipitates, which will help to discriminate between the other types of secondary glaucomas. Usually, there's a ruptured hyaloid phase, but it may not happen, as we've discussed. And if you do a gonioscopy, we can see a normal appearing open angle or an open angle covered by a fine layer of khaki colored cells. And sometimes it can have appearance of a pseudo hypopion, like we are seeing it's appearing like an hypopion. And sometimes this can even be confused with a post-operative endophthalmitis. Now, the vitreous has the appearance of an old hemorrhage. And what are the differential diagnoses? It can be angle recession glaucoma. It can easily be differentiated by gonioscopy. Hemolytic glaucoma and hemocyderotic glaucoma, which we'll subsequently discuss. Uveitic glaucoma, here there will be no keratic precipitates. Neovascular glaucoma, it will have typical findings. And acute angle closure, because sometimes mechanical injury secondary to glaucoma can cause anterior lens subluxation and can cause a secondary angle closure glaucoma where the IOP may be very high, but then this can usually be distinguished from the typical clinical features. So what are the investigations that we need to do? Usually only history and clinical features are they suffice to clinch the diagnosis. For spontaneous hemorrhages, CBC coagulation profile and sickle cell preparation can be advised. And historically, the diagnosis of ghost cell glaucoma was made by this phase contrast microscopy of antechamber aspirate, paraffin embedding after centrifugation of AC aspirate, or staining of the sample with 1% methyl violet. I'm just stating it for the completeness of this topic. And if hematoxylin eosin preparation is done, then this Haynes bodies can be detected. What is the management of ghost cell glaucoma? So we should remember that it's not a permanent condition, but it may last for months before the abnormal cells eventually clear from the anterior chamber angle. We should use standard anti-glaucoma medications like the beta blockers or the carbonic anhydrase inhibitors. The surgery might be required to clear the cell load from the trabecular meshwork by AC paracentesis and irrigation or a pars plana vitrectomy. So there have been reports in the literature where the IOP was not controlled, but the patients with ghost cell glaucoma required a pars plana vitrectomy, because once we remove the reservoir of the glow cells from the vitreous, the IOP will come to normal. And for refractory glaucomas, which are caused by the chronic obstruction of the trabecular meshwork by the ghost cells, they can require surgery, like trabeculectomy, or the glaucoma drainage devices. Next, we come to this hemolytic glaucoma. It's a rare form of glaucoma, again in the setting of traumatic vitreous hemorrhage. What happens is that here the macrophages ingest the contents of the red blood cells and they accumulate in the trabecular meshwork. So you can see this in this slide. There's a macrophages which ingest the contents of the red blood cells, and they block the trabecular meshwork, and they can cause this glaucoma. The numerous red tinted cells are seen floating in the aqueous, and the angle is typically open, and reddish brown pigment can cover the trabecular meshwork. It's again a self-limiting and it's managed medically. Rarely it may require AC lavage or pars plana vitrectomy. Then the last type of glaucoma in this setting is a hemocyderotic glaucoma. Again, it's a rare form of glaucoma, but there are reports in literature. It can present many years after trauma. So it's an important finding, many years after trauma, and it results from a long-standing vitreous hemorrhage or retained intraocular foreign body of iron. The hemoglobin from the lysed red blood cells in the AC is phagocytosed by the endothelial cells of the trabecular meshwork, and the iron in the hemoglobin subsequently causes tissue alterations in the trabecular meshwork, and it causes reduction in the aqueous outflow and secondary open-angle glaucoma. The important distinguishing features are that it is more chronic compared to the glaucomas we have discussed. There are no ghost cells, and only the slight discoloration of the trabecular meshwork. So that is the end of the presentation. I would end by summarizing the key points. So the red blood cells in a fresh or degenerated form in the anterior chamber can lead to elevated IOP by obstructing the aqueous outflow through the trabecular meshwork. And the most common cause of hyphema is a blunt trauma. Glaucoma may result from initial hemorrhage, but it can it's more common following a riblet. And the initial therapy is directed towards accelerating the resorption of the hyphema and minimizing riblet. When glaucoma occurs, medical management usually controls the IOP, but some cases do require surgical intervention, which will require the removal of the clot. Hyphema in the setting of sickle cell hemoglobinopathies require aggressive management, as even moderately elevated IOP can produce rapid damage to the optic nerve. The other causes of hyphema include spontaneous bleeding from tumors, neovascularization, or rarely vascular tufts on the pupillar margin. The most common form of glaucoma associated with degenerate ocular blood is ghost cell glaucoma, in which degenerating erythrocytes obstruct the aqueous outflow, and this can follow cataract extraction, vitrectomy, or trauma. Other situations in which degenerated blood may lead to glaucoma include hemolytic glaucoma and hemocyderotic glaucoma. Thank you. Thanks for the opportunity, and thanks for the patient listening.
Thank you very much, Debasis. That was real comprehensive coverage of glaucomas associated with intraocular hemorrhage. You actually have made the next lecture much lighter. Chandrima is doing that lecture next week, Chandrima Paul. Anyway, so unfortunately, both our chair and co-chair are busy elsewhere, chair in another meeting and co-chair on a personal visit, emergency visit to Bombay. or Mumbai. But there are a few, points that I would like to clarify, points that are raised from your presentation. Now, it is very clear that, sickle cell anemia, sickle cell disease, and glaucoma associated with bleeding in such a disease, or bleeding per se in such a disease, is difficult to manage, and that Diamox should be avoided at all costs, simply because Diamox can cause systemic acidosis, which then precipitates sickling. But I believe you also said that CAI should be avoided in hemorrhage. Do you
No, in hemorrhage associated with sickle cell disease?
With sickle cell disease?
Yeah.
Do you believe that enough absorption takes place for a systemic acidosis?
No, it is debatable. It is discussed that whereas systemic acetazolamide are absolutely contraindicated, topical carbonic anhydrase inhibitors, there is a doubtful role. But some authors have suggested that if possible, you should take the help of other medications and avoid topical carbonic anhydrase inhibitors as well. But definitely the risk of acidosis is much less. The topical absorption is much less.
Because you see, what you're doing is we are ruling out prostaglandin analogs for several reasons. So we are only left with alpha adrenergics or beta blockers if we are also not doing carbonic anhydrase inhibitor. So we are actually limiting ourselves. Sometimes the pressure may be so high and you may have to temporize for a period. So whether a topical carbonic anhydrase inhibitor could be tried under those circumstances.
Yes, true.
What do you think?
Yeah, right. Like in most cases, it's very difficult, or we do not know that the patient has sickle cell anemia. So we just see a patient with a high FEMA, and we do not really investigate whether the patient has sickle cell anemia or not, unless of course it's a known patient.
But quite often they come, can come with a diagnosis. True.
Yeah. Yes.
Okay. A point you raised in your presentation is that corneal blood staining starts clearing from the limbus from about 3 years onwards. Is that actually true? Would you wait that long? Would you wait that long?
No. The corneal blood staining, it clears from the periphery, and it takes a long time to clear. It can take up to 3 years to clear. So we should not wait at all. You should. There is always a risk of permanent.
Because blood staining by definition is because of high pressure, isn't it?
Yes.
The blood cells are being driven into the cornea because of the pressure that is present in the eye. So it may be the natural history, and that is something I've learned today. I did not know that it can clear by 3 years. But yes, definitely one should not wait, because of course it's causing blindness. It's causing loss of vision. This is a very personal thing for me because my brother suffered from it. But
particularly in children, there's also risk of amblyopia.
Yes. The other point I wanted to raise was your, when you said in the management, the role of cycloplegics and that of topical steroids. Cycloplegics, you talk more in terms of inflammation, but does it have any role in preventing a rebleed? Do you think? I give it all the time.
Yes.
I'm a great believer in cycloplegics.
Yes. Cycloplegics should definitely, there's a definite role. So it will reduce the pain, it will reduce the inflammation, it will reduce the fibrin, and it will reduce the formation of posterior synechia also. So definitely, cycloplegics are absolutely indicated.
Those are all from the point of view of inflammation. What I believe is that what it tends to do is it tends to stop the movement of the pupil, as a result of which the displacement of the clot and perhaps a rebleed then does not occur.
Okay.
Does that make sense?
Yeah, that's quite possible.
because it immobilizes the pupil and does not cause any movement of the iris or the pupil, as a result of which the clot does not get displaced. As a result of which you may be able to minimize any rebleed, which we know is potentially more dangerous rather than the primary bleed. Rebleeding is what we worry about, isn't it? Most of the time. Yeah. And what about steroids? What do you think the role is? Do you think it actually reduces fibrin?
Yeah, it has been written in the textbooks that it reduces the amount of inflammation, it reduces the fibrin, and it reduces the pain.
Sure, but quite often when I said when it reduces fibrin, I actually meant reduces the amount of hyphema. You may not get inflammation at all. You know, you get inflammation maybe in the scenario of intraocular surgery. There definitely steroids are needed. But what about when a patient has had blunt trauma and has bled and does not have much inflammation?
I think in case of blunt trauma, again, these topical steroids are helpful. Okay. Topical steroids, helpful.
And what about anti-fibrinolytics? You talked about the oral tranexamic acid or so on and so forth.
Right.
I think, or don't you think that their utility is reduced because of its intense hypotensive reaction? It tends to cause a lot of giddiness and a lot of low blood pressure, in addition to the thromboembolic events that it can cause elsewhere.
Yeah, it has significant side effects, particularly in patients who have cardiac disease or associated renal disease. It can cause postural hypotension. But in patients who do not have these complications and who have very significant hyphema and there's a risk of rebleed, then this oral because we use them, the other specialties use them quite frequently when there's a bleeding in elsewhere. So for those patients, if we can rule out the significant side effects, significant cardiac disease and all, they can be used in such patients.
Right. When you say other specialties, who do you mean?
Like general surgery, bleeding anywhere.
Okay. Yeah. Not other specialties of
no,
ophthalmology.
No.
Yeah, we better be clear about these things.
Yeah.
Okay. I'm really glad you showed that video very clearly. It showed what can be done, and also that the fact that you showed that it can, if it is stubborn, we can remove it with the vitrector, and that the AC should be formed all the time. So, all the principles very well demonstrated. There's another question which asks what is the maximum time for ghost cell glaucoma to develop after the bleed in the vitreous or the AC? Is there a time?
There is no, I could not find any reference to what is the maximum time can occur, but it can occur after several months. That has been discussed. It can occur several months after the initial event of the vitreous hemorrhage. That because the transformation of these RBCs in the ghost cells occur in a few weeks' time, but they can remain in the vitreous and they can come anteriorly, and this can happen many months after the initial event.
Right. Okay. Thanks very much. There are a few hot seaters here. I think Rolika apprised you of their role. They weren't asked any questions, but I'm giving them the opportunity to ask you questions. Do you have any questions that you need clarification on? Hot seaters today? Dr. Soni, Dr. Jeeba, Dr. Sami, Dr. Anshukita? No?
No, ma'am. And thank you, sir, for a great class.
Great.
Thank you.
See, instant feedback, Debashish.
Thank you, ma'am.
Yes, it was a great talk. Well, thanks very much for your time. Thanks very much for your effort. Like I said, it was very comprehensive, covered all aspects, and that you've made Chandrima's life very easy. Okay. So good night. We are actually out of time. He covered quite a bit of details. So we'll leave the discussion about a case for next week. Sunil ji, 10 minute time hai to karenge, nahi to fir next week karenge.
Yes, ma'am. Always the time. No, don't.
Always a time. Great, fine. Let's give the hot seaters a treat today. Okay. Debashish, if you want to leave at this point, you're more than welcome. But at this, here is the section where I discuss a few cases with, just as a what we call, revision of all the concepts that they are supposed to have grasped through these glaucoma modules.
Thank you, madam. Thank you for the opportunity. Thank you.
Welcome. Good night.
Good night.
Okay, guys. So, hot seaters, we are doing a case today of a 69-year-old male. He has history of retinal detachment surgery in the left eye, and he was advised a PJ analog previously, but he's not doing it. And when I examined him, his vision was 20/20 in the right eye, 20/60 paths in the left. He had pseudo exfoliation in both eyes, and posterior chamber IOLs in both eyes, and his pressure was 13 and 34. And gonioscopy was open in the right eye. 270 degrees, it was seen in the left. Superiorly, it was not clearly visible when it was open because there was quite a bit of silicon oil emulsion. So these are his discs. Now, this is one thing I wanted to stress upon. This is the way to present your, any glaucoma. In short, any glaucoma cases. You need the vision. You need your slit lamp findings. Please remember, you cannot diagnose primary glaucoma if secondary changes are present, and so on and so forth. Then you need your Goldman applanation and you need your gonio, and followed by your fundus evaluation or whatever you see. So this is his right eye. I see two new doctors in today. So can I ask Dr. Anshikita if she's still there? How would she describe this disc? It's a little bit tricky, but we'll help you through it. Are you there, Dr. Anshikita? She's
Dr.
not
Sami,
there.
would you like to take that?
Yeah.
Yes, ma'am. Ma'am,
Right.
this is a small disc, bit tilted,
Okay.
with a small cup to disc ratio of 0.3:1.
Hello.
Hello?
We've forgotten our 5 points. Don't jump to
Yes.
CDR first. I hope
Okay, ma'am.
you have attended the lectures on disc assessment and all the discs that we have seen so far. The idea is to get the size and shape, of
Size.
course, and tilt, whatever. Then
Margin.
second is margins, yes.
A neuroretinal
Third is,
rim.
that is neuroretinal. Okay, margins and neuroretinal rim. Then
The CD
No.
ratio,
nerve fiber layer.
nerve fiber layer.
Any presence of any disc hemorrhage and peripapillary atrophy. So now start
Sorry,
again.
ma'am.
Yeah, these 5 points are non-negotiable, if you ask me. And more so because you want to be a good glaucoma doctor. Even if you don't do glaucoma as a specialty, you should be in a position to diagnose the disc as glaucomatous or non-glaucomatous. There is no excuse for misdiagnosing glaucoma. And the only reason you misdiagnose glaucoma, believe me, is because you jump to the CD ratio. There is no normal level of CD ratio. Just put that in your head. There is no normal level. Okay?
Yes,
Start again.
ma'am. So this disc is a small disc with clear margins. The neuroretinal rim looks healthy.
Okay.
The retinal nerve fiber layer is normal. There is no disc hemorrhage visible.
When you say normal, what do you mean? Are you seeing nerve fiber layer Texture and pattern? I've put the other eye for
Yes, ma'am.
comparison.
There is visibility of the retinal nerve fiber layer in the right, not in the left.
Very good. Excellent. What about disc hemorrhage?
There is no disc hemorrhage.
Okay. Peripapillary atrophy?
Yes, ma'am. There is peripapillary atrophy inferiorly.
Okay. So is that significant? Do you think it's significant given you have said the neuroretinal rim looks healthy and there is no nerve fiber layer?
Ma'am, because it is a tilted disc and it appears in both the eyes, the peripapillary atrophy.
Okay.
So maybe it's
So
a normal finding.
Okay. How's the left eye different from the right eye now? Find the differences.
Yes, ma'am. Ma'am,
this is the disc of my background. The left one.
Yes, ma'am. Ma'am, the disc in the left eye it appears bigger than the bigger in size than the right eye in the left eye.
Yeah.
And the neuroretinal rim is missing in the nasal side. Nasally, there is thinning in the neuroretinal rim.
What is important in glaucoma? Nasal? Which two rims are important in glaucoma?
Superiorly and inferiorly, ma'am.
So that is what you need to comment about first.
Okay, ma'am.
Nasally, I don't think it is missing, but that's beside the point. Superior and inferior, tell me.
Superiorly and inferiorly, ma'am, comparing to the right eye, it appears thinned out.
Okay.
If I compare it with the right eye.
Which one more, superior or inferior more?
Superior.
Really? Where are you seeing the blood vessel bending inferiorly? I don't see the blood vessel bending there at all. It may be bending there, that being the margin, and then I see it bending there. So what does that show you?
Inferiorly, it is more thinned out.
Yes, compared to superior, at least superior you're seeing, but it is slightly tilted, and so there may be slight difficulty when you're looking just at photographs, but you have other clues. What is that other clue? What about this area? You already talked about it.
The RNFL.
Yes, look, this RNFL appears to be the least amongst the 4 poles. Okay, always compare with the other eye also. Then look at the beautiful pattern, look at the brightness in the RNFL on the right side. But on the left side, this appears to be the least, then this. Okay, so inferior less than superior. So what you seeing peripapillary atrophy? So here the peripapillary atrophy may be significant compared to the right eye, isn't it? Remember, peripapillary atrophy is not a definite sign. It's not a highly suggestive sign. It's only a moderately suggestive sign. If you remember, I don't know whether you've attended my lecture, I have given a full list. That list is, it should be your Bible for glaucoma. Oh, sorry, I should not be using the word Bibles. That should be your whatever you follow, whatever religion you follow. Okay. So this superior rim is still present, but the RNFL does not look that great. Now look at the RNFL on red free. Very tessellated background. That's all right. Nothing to worry about, but I still see a lot of texture on the right side. Reduced superiorly left side, much reduced inferiorly left side. Okay. So superotemporal, slightly less, inferotemporal, much more. So what is your assessment here? Given that his pressure is 13 and 34, was it? Mm-hmm. And he has pseudoexfoliation both eyes. and he has had retinal surgery in the left eye. So now, what do you need? You need a visual field. You need to find out whether there is a correlation of the structural with any functional change. So what are you seeing on the right side? Do you think that's normal?
This enlargement of the blind spot.
Mild enlargement of the blind spot. Yes, I will agree with that. Perhaps related to the peripapillary atrophy also. But what you need to talk about is first look at the reliability parameters. Please don't forget how you're going to answer about discs, about visual fields, about OCT. All of them should be in the way that you have been taught. Okay, so reliability parameters are acceptable, do you think?
Reliable.
Foveal threshold, very good, isn't it? Even though the patient is 69 years of age. All right. And what strategy has been used? Yeah, so you have to say that with a size 3 stimulus. And what do we mean by white? Means it's white on white perimetry.
White.
Yes. Okay. So generally speaking, within normal limits, right side. You would agree?
Yeah.
What about the left side?
The left side is also theta channel strategy with stimulus 3 white on white.
Very
and
good.
the test is reliable, but the foveal threshold is decreased.
Yes. Good.
And if we see the total deviation, we
Yes.
can see superior and inferior defect,
Yeah.
which is breaking into the periphery.
Mhm.
But if we see the pattern deviation,
Mhm.
there is
Does this satisfy
error.
Anderson's criteria? Anderson's criteria is also something you need to have on the tip of your fingers. Okay. If you don't remember offhand, please go and have a look again. Okay.
GST is outside normal limits, and P non-contiguous point less than 1%. Less than 5%. One of which is less than 1%.
Yes. So this is significant, isn't it? Where is the defect?
It's in ma'am, it's a nasal step.
Yeah, it's supranasal. Whether you call it a nasal step or not doesn't matter. Okay. So does that correlate with the change you saw in the disc?
Yes, ma'am.
Yes.
Because it
So,
was inferior and the field.
Exactly. So the inferior was looked RNFL and the rim looked the most damaged. Okay. And this visual field change is correlating with that. Okay. Anyone else wants to try now? The OCT I'm going to show. I don't want to put Sami on on the spotlight anymore. So this is, I just put it in to show that, this is your actually left side. So when you keep the visual field, it is always on the left side, right on the right side. But when you keep your photographs, right and left. Okay, please don't forget that. Otherwise, you miss neuro-ophthalmological visual fields. Okay, who would like to comment about the OCT now? Dr. Soni?
Yes, ma'am.
Mm-hmm. Tell me, what does it say? So first you have to talk about the image quality. Do you think it's acceptable? This is a cirrus, sorry, that has been cut off.
Ma'am, no idea about the image quality.
Image quality, yeah, you need to know about those as well. Okay. I'll next time I'll give you a slide in which it'll give you an idea. You can take a screenshot. Okay, comment about the Actually, this is not the cirrus. I'm really sorry. This is actually Triton. Triton is a OCT angiography. A machine which is capable. It's swept source, so it's capable of OCTA. Okay, tell me.
Oh.
Doesn't matter. The principles remain the same.
Okay, ma'am.
Tell me.
Ma'am, inferiorly we can see red area more.
Which side?
It's showing on the right side, but
is a red area in a thickness map worrisome? No. So around your disc, superiorly and inferiorly, can you hear me?
yes, ma'am. Yes, ma'am. I'm
Yeah, superiorly and inferiorly, it's pretty thick on the right side. Okay. Is that correlating with your clinic?
Yes, ma'am. It's correlated.
Disc that we just saw? It is.
Yes.
Okay, good. What about the left one now? It is not showing as much warm colors. The red area also seems to be reduced compared to the right side, isn't it?
Yes, ma'am.
Okay, but when
Yes.
it is computing the quadrants or even the clock hours, what is it showing?
Ma'am, nasally, it's showing in the left eye. Nasally, there is a defect.
No, that's not a defect. White means it's higher than normal.
Okay.
It's not lower than normal. And don't worry about nasal. What did I say? What are we
Yes.
worried about?
Superior.
Superior, inferior. Please get it into your head. Very important. Superior, inferior. Glaucoma, superior, inferior. Forget about nasal. Forget about temporal. Nasal is the last rim to go, believe me. Your temporal island of vision is the last to stay before the patient loses vision. Okay. So what we are seeing basically is that the OCT is normative, meaning both sides, it seems to have passed where the age-matched normals are concerned. Okay?
Okay.
But does that now correlate with your disc finding?
No, ma'am, it doesn't correlate.
Exactly. So what point am I trying to make here? That there is green disease on OCT. Okay. I personally wouldn't have done that OCT. I can see the RNFL defect. I can see the rim that is thinned, inferior rim that is thin. But this is a colleague who had actually already done it. So I just took the images to show it to you guys. So this is what is known as green disease. You're actually seeing a change in the eye. You're picking up that change. And yet on OCT, you're seeing that it is coming up as normative, meaning it is not very different when it's compared to age-matched normative database. Okay. So what's the diagnosis? Not only is it both eyes no, it's not cataract. I'm really sorry. Patient is pseudophakic. Very, very sorry. And there is left eye secondary glaucoma. So if there is pseudo exfoliation on both sides, but you're only seeing changes in one, and the changes seem to be secondary to retinal detachment surgery, so then it becomes a secondary glaucoma, most likely after the surgery for retinal detachment, where silicone oil was inserted and also removed. Is that clear?
Yes, ma'am.
Yeah. So always you have to strive to correlate, and always your clinical finding is paramount, not your OCT and not your visual field. Quite often in circumstances, see, it was such an early damage. If the damage was not showing up in the visual field, did it mean that you did not have the change in the disc? No, it would have been pre-perimetric changes. So the top tip here is that OCT showing green disease does not rule out disease. Please remember the limitations of the machine. And in this particular case, can you name me at least one limitation? What is the limitation?
Ma'am, limitation 2, ma'am.
No. What was the limitation for which this OCT showed green disease? Meaning, you know, it showed normative everywhere.
Maybe because of image quality.
No, image quality was fine. In this particular case, because of
Peripapular
disc.
dead disc.
Generally a problem and pick up, but it was tilted. So very large disc, very small disc, tilted disc, myopic disc. Myopic disc generally associated with a lot of peripapillary atrophy where you can't even find the margins clearly. Those are the limitations of the OCT machine. All right?
Yes, ma'am.
Clear? I hope so. All right. So that's it for today. I think we are way above time now. So next week, we are expecting Dr. Chandrama Paul with glaucomas associated with ocular trauma. There'll be a considerable overlap, I feel, with the very extensive way that Dr. Debasis delivered his lecture. But it's good for you guys because I think it helps you to, repetition helps you to remember facts. Okay. Thank you very much for your time. Thank you for attending and see you